This conference will now be recorded.
Good afternoon, everybody. Thank you for your patience as we work through some technical difficulties. My name is Matthew Cole from Michigan Planners, and happy to be joined by the Apostrophe team today. Specifically, I want to introduce Jesse Gomez from Apostrophe Health. How are you doing, Jesse?
I'm good, thanks. Thanks for having me, Matt. It's a pleasure and an honor to be here.
Well, thank you, and thanks for joining us. So today we were going to have Jesse go through a presentation here. Right now we have him by phone, so we're going to try to do my best to. I'll be his MC. I'll be his slide translator, and we'll just have an open dialogue about Apostrophe Health and maybe how it might be a good solution for your organization to consider. So before we even jump into the slides, Jesse, maybe you could just spend a minute or two sharing a little bit about your background and then really what Apostrophe Health is and how this organization came about.
Yeah, happy to. Thanks for the opportunity to do so. So I have been personally in healthcare for coming on 26 years now. I've spent most of my time on the consulting advisor side of the table, predominantly working with large enterprise accounts and helping self-funded plans design cost containment strategies, engagement strategies, and the like. And been through a number of different executive level roles with different companies since I should back up and say that at one point I ultimately opened my own brokerage consulting firm, had a really successful exit there, and since then I've been working with hyper-growth, venture capital-backed companies who have a mission, I believe, in bringing about systemic change in healthcare, particularly around the delivery and member experience. I joined Apostrophe Health in December of 2019. I lead the sales and marketing functions for Apostrophe Health. And a little bit of background for those who aren't familiar with Apostrophe. We are Apostrophe Intelligent Health Benefits essentially replaces your current administrator, your legacy network provider, to deliver what we believe is better benefits for less money to self-funded plan sponsors. We were founded in 2017. We are based in Denver, Colorado. But many of our clients are located across the U.S. with large and growing footprints and a few core markets that includes Michigan, of course, which is a mitigating factor in why we're together today, Indiana, Texas, and Colorado. And our clients span both public and private sectors. We are a certified B Corporation and backed by a few high-profile venture firms who are helping us to build what we believe is a fast-growing and sustainable business grounded in our core values.
Well said. So I take it Apostrophe sees an opportunity in the marketplace, even though there's some large carriers already kind of dominating the United States. There's really 4 or 5 if you start to name them off. What about Apostrophe Health? Do you believe or allows you to differentiate or compete in a marketplace that I can summarize in 3 or 4 carrier names: Blue Cross, United, Cigna, Aetna, for example?
Yeah, I think that's a great question. I'm glad you asked it. And I think it's, there may be a few things that I say through the course of this conversation that may seem provocative to some, and it's intended to be. First of all, we maintain that healthcare is not broken. It is working exactly as it's intended to be. Oops, am I there?
We got you back. Yep.
Okay. What I started out to say is that I don't believe that healthcare is broken. It's working exactly as is intended. As prices increase, providers and carriers both mutually benefit from top line revenue growth. And there's a slide within my presentation that is one that's depicting the stock prices of the major carriers and health plans, and it demonstrates how significantly they've managed to outperform the S&P over a period of time. So from a self-funded plan sponsor's perspective, it's always strikes me as a little bit peculiar that there is this obscure perception or expectation that the major carriers, if you will, are going to actually advocate or negotiate for the lowest possible price on behalf of them as a partner, when in fact it is directly contradictory to how they go about making money, or it's at odds with how they go about making money. So one person's top line revenue growth for the same product or service comes by the way of the willingness for another to pay for it. So we are different. More specifically answer your question is that we don't contemplate network agreements. We leverage the plan sponsor's purchasing power at a local level to contract directly and change the way we've actually really significantly rewired the way that members and plans pay for care. And I hope we'll get a chance to talk about that in a little bit more granularity.
Yeah, and I would add that, to help level set, Apostrophe Health works with self-funded customers only, whereas the major Blue Cross, United, Cigna, Aetna carry both a fully insured and self-funded portfolio, heavily fully insured, depending on the location. And those contracts that are created with providers are the same whether a group is fully insured or self-funded. And why I mention that is because groups that are fully insured, the carriers themselves, their profit is predicated on minimum loss ratio standards set by the ACA. So that's one thing that the ACA put forth, forcing carriers to only be able to maintain a 15% margin on claims costs, meaning really the only way to increase their revenue is to increase the cost of those claims or the cost of services in general. So I think, if I could say it a little bit differently, Jesse and the Apostrophe team really takes a different approach because they don't have a fully insured portfolio with ACA parameters to follow. It's about truly leveraging the provider network and negotiating the best price for the best service. Jesse, anything else to say about we're on the stock market slide, and I should have invested in one of the BUCAs back in 2009. That's what I can believe.
Yeah, no, I think I've said enough about where it is. You've done a great job of also further level setting in terms of where their priorities are, and so why it is important for self-funded plans in particular, to have that perspective.
Yeah. So now let's dive into really. You have a slide here that says the evolution of self-funding, but I'd even start at fully insured. We have several clients that are likely on the call that are sitting in a fully insured plan. What advice do you have to them about maybe taking the jump to self-funded that would help them have a level of comfort that maybe otherwise has held them steady in the fully insured environment? And I think then we can get into the different versions of ASO plans and the evolution that Apostrophe is bringing to the market.
Yeah, in fact, if this slide that you're referencing, and I do have it up now, and my computer rebooted, so I do have the deck up, but I'm still not able to log in for some strange reason. But this visual, it in fact contemplates further to the left prior to the ASO bundled would generally be a fully insured plan. And the intent that my recollection, or excuse me, my perspective on that is that if a plan really wants to take control over their costs, take control over their member experience, and again, something maybe a little bit more provocative is if they really want to be less of a pawn in this game of health insurance, they will move towards, and I'm certain that you and Michigan planners do a fantastic job of helping member plans to really understand this. But the only way that they can take control of those costs and member experience is if they're willing to venture into the realm of self-funding. In the absence of self-funding, they really are just victims or pawns to a great extent, and certainly don't lack lack control over their spend and experience.
Yeah, at that point, we're really looking at carriers and rates, and it pretty much begins and ends there. So as we evolve and look into a self-funded package, you have kind of three buckets here. Do you want to comment a little bit about how we advance from one to another?
Yeah, and a plan could skip, let's say, one, particularly if they've got a level of sophistication and a great advisor helping them to navigate them through this process. But this is a generalization. So just to be clear, I'm really kind of generalizing here, and sort of what I would say is sort of the life experience of a plan moving from fully insured to a traditional ASO bundled program, which is generally described as very rigid, no ability to implement cost controls, poor member experience, and of course they're generally also part of the BUCA network in that example. And as the plan kind of grows and matures a little bit, they'll venture out and they'll seek to take greater control over their spend and experience, and they'll move to a TPA unbundled product with the hope and expectation to gain additional control over those two items. And it's been my experience that, again, one of the constraints to that plan is that they're still subject to network contract discounts from bill charges. They are oftentimes trying to themselves navigate and or implement point solutions that they feel best address their population health, and or leverage you, Matt, and your team to try to figure that out. And it's been my experience that endeavor ultimately results in a poor member experience. And then still, again, be reminded that even if you're very successful in the bottom two in improving a member experience and implementing good point solutions, you're still ultimately subject to purchasing agreements and contracts that have been negotiated on your behalf, as we described earlier, that really don't benefit you. You've given up your purchasing power at the local level. And so if you move one step further, what we have called intelligent health benefits, I think, is sort of the culmination of all of what works in the prior examples, and then replaced what doesn't work with what we know to work in the marketplace. And so giving the plan sponsor greater freedom and control, teaching them and acting on their behalf in most instances to purchase healthcare using common sense and proven methods, a tech-enabled and integrated platform that integrates all of those point solutions in a meaningful way, that ultimately provides and is wrapped around a great or white glove member experience that really, I think, is unique to the industry, that is a true advocacy program. And of course, we leverage plan design and steerage in the design of that in a really meaningful way. And so that's what we've called intelligent health benefits. And of course, we don't contemplate networks, so plans don't have to worry about who's in network and who's not in network, which is becoming a bigger problem today as we contemplate surprise and balanced billing.
So if I could paraphrase and maybe summarize or dig into this a little bit, if we work our way
Sure.
from left to right, an ASO, that acronym really just stands for a self-funded administrative service agreement with a Blue Cross, United, Cigna, or Aetna. When we talk about the term TPA, it would be a third-party administrator, not named one of those 4 or 5, that rents one of the national networks, typically a PPO network. So we're still in the confines of those contracts with those providers specific to what either is rented or owned by Aetna, Cigna, United, Blue Cross. And then really what Jesse's talking about on the far right, and Apostrophe's model we'll continue to dig into, is Apostrophe was built on not really establishing a PPO network. It's an open network, as Jesse will talk about, and it's priced and predicated on Medicare principles and reimbursement strategies, amongst other things. And beyond the pricing of the service, and I think this is really where Apostrophe has done a great job in the marketplace, is helping to understand what your members need in order to effectively navigate healthcare and use healthcare efficiently. So when you think about some of your worst customer experiences, it doesn't have to be in healthcare, just in general. I think Apostrophe took a open-eyed approach to say, where can we really step in where maybe the market hasn't fully adopted a service model that makes a lot of sense to the end user. Did I represent your belief or commitment correctly?
Yeah, I think so. We actually think that our member care team is the heartbeat of our company. There is so much that they do that goes really, quite frankly, above and beyond anything that I have ever seen any other company do in my 25 plus years from a member care or a service team. It's not surprising. A lot of our team members come from hospitality and other industries, and so it is a truly unique experience. They are not constrained by the amount of time that they can spend with a member, helping them to both understand their benefits and navigate them to the wisest choice for them, with all of the data points that would help a rational person arrive at a good decision.
I think you touched on some of this, and I'm now on the slide where I think most people will recognize these big names: Walmart, General Motors, and Lowe's. And you said follow the leader. So what do you mean by that?
Yeah, admittedly, what we're doing at Apostrophe is not net new to healthcare. Many of the most sophisticated self-funded plan sponsors have already demonstrated success with many of the functions that are within our business model. What we have done really successfully is aggregated what are known to be best practices, implemented best-in-breed solutions, and brought them to the mid-market in a really meaningful way. We recognized that the mid-market was grossly underserved, and as a result of not having, let's say, the big dollars and the big teams of a lot of these companies that are referenced on this slide, don't know how to leverage the things that these companies have done in market. And so we come to market with the understanding that if we can bring everybody together in implementing some of these best practices and leveraging the purchasing power of the health plan directly in market, we can negotiate contracts directly on behalf of the plan, let members pick and choose the care that where they want to go, and then negotiate favorable rates on behalf of the plan. And that's really all that much of Walmart, General Motors, and Lowe's have done. It's nuanced a little bit more, but it's big bucket items. That's really what we're talking about.
Well said. Moving on to the next page here, kind of, I think, encompasses a lot of your philosophies and belief. I won't dig into it. I'll let you kind of share, but I want to make sure you spend some time on the member care, member pay experience, because I think that's a big differentiator for Apostrophe.
Sure. So I'll run through these relatively quickly, and then we can, but if there's anywhere you want to dig deeper, by all means, please stop me here. But I think that if there was one slide within our deck that we should be focused on, it would be this one. It really describes what are, at the crux, what are our differentiators. And these are the strategic level components that really make us different. And you notice at the bottom, we've outlined savings and experience. We are focused on two key areas. The left side is demonstrable of everything that is savings oriented, whereas the right is really more experience focused. We've architected our solution in a way to maximize both for each of our stakeholders, which we consider to be obviously the plan sponsor, and we view ourselves as stewards on behalf of the plan sponsor, but huge advocates on behalf of the member. Of course, the consultant, and working in partnership to design programs and communicate the plan in a meaningful way. So we view the consultant very much as a stakeholder as well in this process, and the provider ultimately. And I genuinely believe that no other administrator or health plan stewards the assets of the plan and or advocates for members the way that we do. On the savings side, beginning at the upper left-hand side, the benefit architecture, designing plans that drive the right behavior before, drive the right behavior to incentivize members to the right quality of care, establishing the appropriate touch points to ensure member education, and that members would naturally choose higher quality, lower cost providers. Under the concept of choice architecture, this is something that we contemplate and design to ensure that we use trusted cost and quality information and it is leveraged to guide members when they're seeking care. And then under the direct purchasing, this is something that we could spend an entire presentation on, but what it really means is that there's lots of levers that we are able to pull here to help achieve the best price for the plan and the plan's members. This can include things like cash pay, prepayments, bundled case agreements, single case agreements, and more, and certainly reference-based repricing. Our long-term objective here is to leverage the local purchasing power of the plans that we represent to secure direct contracts. And so there may be times where we do leverage reference-based pricing as a core tenet, but we are certainly not your typical reference-based repricing plan. And so I've said kind of a lot there. Do you want to ask me any questions or make any comments about anything I've said so far?
Sure. There's a lot there, so I think we'll dig into it a little bit. Reference-based pricing for those on the phone. Let's just set that aside for a second. I think we need to spend some more time on that. But benefit architecture, I think this is important that you touched on. If you go back to the slide of the evolution of your self-funded plan, and even think about it from an insured plan to start, what Jesse's really talking about is, I think most employers are used to getting some information about trying to steer your members to go use a lower cost MRI facility. That's probably the cliche example. In an insured world, typically the best we can do is give them a gift card or a check, maybe a small check if they go and do that. Where I think, Jesse's really alluding to as far as benefit architecture is, if we know that there's 10 MRI centers and 2 of them are lower cost, high quality, and they're $500, and the other 8 are $3,000, why not make the plan make the cost free to the member if they go and use one of the low cost, high quality providers? So I think that's really some of the components that Apostrophe has the ability to really pre-build in a plan design, and ultimate flexibility where it makes sense when you dig into some of the data. So that's my first comment there. Another comment I'll make on the direct purchasing plus provider pay piece. So Jesse mentioned cash pay. I think everybody in the world likes cash. And if you're not familiar with how our health system works, there's typically a time lag between when a provider provides an actual service, bills a ASO, TPA, Apostrophe, whatever name convention you want to use, and they actually get a check cut to them. So depending on the circumstance, that could be 3 weeks, could be 5 weeks. I mean, sometimes we see bills lingering out there for months, depending on the complexity. So offering cash pay in some instances can help those providers consider a lower service cost. And then the second piece on this, I think that's really important, and if you want to piggyback on this at all, Jesse, feel free to, the provider pay on the member side, right? So you're also paying the member's portion when you pay the provider. Is that correct?
That is correct.
So folks, today you go. Oh, go ahead, Jeff.
There's, if you want me to elaborate a little bit further on that, is why I'm sure people on the phone may be going, well, why would you do that? Why would you sort of make the plan responsible for the member's share of the cost? And that would certainly be my initial response, and my reaction and my response is that, again, this gets a little bit maybe too granular, so please stop me if you think this is, Matt, but we actually are able to leverage this in a very positive way to, again, leverage the purchasing power of the plan locally to negotiate a much more favorable rate with providers when we take them out of the collections business. So this gives us additional leverage to negotiate a much more favorable rate on behalf of the plan.
No, that's perfectly said. I don't know the exact stat out there these days, but in my head, I've ingrained that providers spend upwards of 10+% of their revenue generated for the services they provide handling billing, and billing leads to a lot of collections at the member level. So most providers are not in the billing and collections business. They outsource those services, and it comes at a pretty penny. There's that, and then there's also the fact that sometimes they don't actually successfully track down a member cost share piece. So Jesse's exactly right. If you go to a provider and say, I can pay you in full now, but I want you to discount that service by 20%, there are many providers who are willing to jump on board and know, what is it? A bird in the hand is better than two in the bush analogy. I think that's some of the focus or the idea around what Apostrophe accomplishes here with this program.
Yes.
And the other side of it, on the experience, and I know we experienced this as an advisor, is if you've ever had a significant service done, you probably received multiple bills from that same facility. And making sense of all those bills and comparing them to your estimation of benefits seems a little counterproductive when the TPA, ASO, or carrier partner that you're working with is also doing the same thing in the form of an estimation of benefits. Why not receive a bill from the person who's actually the one auditing the claim, which is what Apostrophe does?
Yeah, to us, that just seems like common sense. We provide back to the member one audited statement, one balance to pay. In the event members receive a bill, they're educated not to pay it, but rather to take a photo or send it directly into the member care team. We work with the member if repayment is a challenge for them or paying for those services is a challenge with payment plans or interest-free options for up to 48 months to repay that balance. So again, this is just, I think I mentioned at the onset, our three core values: simplicity, transparency, and love. This is just doing the right thing. Healthcare doesn't have to be this complex. People make it complex so that they can sort of hide behind things and confuse the consumer. We're trying to do everything that we can to make it really, to remove the complexity out of the purchasing healthcare experience.
Yeah, well said. I'm jumping ahead to our next slide, and wow, this is front and center with us today. It's virtual care. WFH, work from home ready. I know there's a lot on this slide, Jesse. Maybe we just spend a minute talking or two about, the expansion of virtual medicine. So not just telemedicine, as many on the phone probably are at least accustomed to some level of, I can call a doc 24/7, get a script ran to the pharmacy. I think you guys are, have many more components to that, and maybe you could just briefly touch on some of those things, and maybe even correlate to how COVID-19 really has, escalated the need for these services.
Yeah, thank you for that. So I mentioned at the onset, I've been in healthcare for a long time, and I've been really in pursuit of trying to do things that will bring about systematic change in the overall delivery of healthcare. And it's always been really confounding to me, recognizing that we have all of these great services that are technology based that really can create greater access, reduce overhead costs for providers, which gives them the opportunity to lower costs. People are always complaining about healthcare costs and access, and here's a great way to solve for some of these problems. But yet, unfortunately, it's taken a pandemic to really give these solutions their day in the sun. And I think, quite frankly, we were purpose-built for this recent change, we being Apostrophe, in the economy and or impact from the current pandemic for a number of reasons. One in particular was that when all in-person, non-emergency healthcare services were shut down, all of our members instantly were able to transition to virtual care for a number of these solutions. So to your point, a lot of people might be familiar with telemedicine, and it sort of replaces, I would say, the traditional urgent care. But there's a number of services that can be delivered virtually and provides some enormous cost advantages as well as confidentiality, access, a myriad of things that really, I think, represent the future of healthcare in a really meaningful way. And these are all standard within our offering. So in addition to telemedicine, members have access to behavioral health with MeMD. They have access to virtual primary care. So one of the big challenges about accessing primary care is how it is inconvenienced in everybody's lives today. Me, myself, my own primary care physician is about 30 minutes away from me. So if I want to go see him, I have to first, of course, schedule an appointment, drive across town about 30 minutes, wait in his waiting room. This is the traditional methodology, right? You can't even do that right now. But then drive, wait, sit in the waiting room, wait until I'm called back for that 3 to 5 minute visit. And then I'm sent on my way. And oftentimes it was just something that, quite frankly, 85 to 90% of those visits can be handled in a much more cost-efficient and convenient way. Could have talked to me on the phone, could have done it using Zoom or GoToMeeting or whatever, some other methodology to deliver that information and or provide me feedback back to me. One of the additional cool things that I've seen come into the marketplace is virtual PT, musculoskeletal care. We've partnered with IMC in this regard. There's a number of studies that are out there that, again, very similar to the example that I gave regarding primary care. Excuse me, I jumped around, but let me go back to primary care. The idea that you could maintain a primary care relationship and have the option of seeing that provider either in a brick and mortar setting or virtually is exactly where healthcare should be. And so, unfortunately, it's taken a pandemic to get us to realize this, but nevertheless, we're moving in the right direction. Virtual PT, musculoskeletal care, there's a number of studies that demonstrate that the people who start down a path of physical therapy never complete it. And part of the reason why they never complete it is because the inconvenient nature for which it's integrated into their lives. They either have to go before work, during work, after work. Everybody's got families and lives and commitments, and it becomes an inconvenience just to get there. And of course, costs are tied to it as well. So the idea that you could do physical therapy at a time and a place that is really, truly convenient for you, whether that's early in the morning or late at night or during your lunch, whatever that may mean, virtual physical therapy actually makes sense. And people who enroll in virtual PT see higher outcome or better outcomes in the adhere to the program more because it fits in their life better. And the last one is second opinions. A diagnosis can be a really challenging thing for people, and the ability to get a second opinion from a group that specializes, let's say, just in whatever that subspecialty may be, can be really helpful for people at times. And again, the ability to access that virtually. So a lot of virtual work from home solutions that are built into our platform, which means that plans don't have to contemplate how to integrate this on their own. In a way that provides a seamless member experience from one care venue or care platform to another is really one of the things that we think differentiate us again.
Yeah, and I'll just add that here in Michigan, we know that the biggest carriers in the marketplace are reporting in their data a 24 to 25 time increase in virtual medicine. So, some of the things that Jesse talked about, providers were forced to really adopt virtual strategies in order to continue to keep their doors open while people were at the stay-at-home order. But our foundation in the industry is not fully built to just transition to virtual care. So that's why Apostrophe, I think, has a model that is plug and play that makes a whole lot of sense. And the last piece I'll say about this slide is 2nd.MD. Just to give you a little more insight, that is a company that's comprised of the best in particular service categories. As Jesse mentioned, it might be cancer care or another serious illness. Having an opportunity to get a second opinion from some of the best in the world, I think, is a nice benefit to add on to anybody's package. But in the interest of time, we have about 15 minutes left, so we'll move ahead here. Let's start talking a little bit about pricing. So, Jesse, I'm on the unit cost savings in Michigan, and there's 3 buckets here: physicians, outpatient, and inpatient. Can you share a little bit about what you see on the commercial side, which commercial would be defined as Blue Cross, United, Cigna, Aetna contracts versus what you're doing at Apostrophe?
Yeah, so a lot of this data really got exposed recently, and of course there are a number of ways that people can acquire this data. They can pay for it, but RAND produced a study recently that revealed a lot of what commercial paid as a percentage of Medicare in various markets were and or are, and so that's captured over on the left. What we've really tried to do is, going back to the savings aspect of it, is really demonstrate really simply how it is that implementing or a program or partnering with Apostrophe can drive meaningful cost savings for a plan. And so contrasting it on the right, what we've really done here is what we're revealing is what we're paying out across our book of business within the state of Michigan against commercial paid as a percentage of Medicare for physician services. So 144 versus 148. Generally don't see a big markup there. That's not what drives companies to change plans. Physician services are generally not a place that we see a tremendous amount of overbilling, but outpatient and inpatient certainly are. And so you can see as we contrast outpatient against what commercial paid in market in Michigan at 202 versus what we're paying at 166. And inpatient at 171 against what we're paying in market as 128. So it's worth noting, I think, that in addition to the unit cost savings that we drive in purchasing services on behalf of our plans, those that are also self-funded and are using stop-loss insurance as a result of this model, they also generally see some stop-loss savings as a result of partnering with Apostrophe Health as well. So it goes beyond the savings that you're seeing in the unit cost here.
So to add a little color commentary, 99+% of providers accept Medicare, all right? And in order to accept Medicare, they have to report on cost and quality to CMS. So these numbers here in this grid are depicting what the average payment they receive from commercial insurance is on the left for each of these three buckets. And then on the right, Apostrophe is showing what they're able to do with respect to some of their strategies that we talked about in the previous slide. So I mean, there's a lot to digest here. Number one is those that come in with a Medicare card pay significantly less. I guess the government typically pays significantly less than your employees coming in with a traditional carrier card, especially in the outpatient setting, an average of 200% here in Michigan. And Jesse works across the country and probably sees numbers in the 300-400%, depending on where the state he's working and talking in. So I just want to clarify a little bit there, but that's essentially the nuts and bolts of how these numbers are generated, and it is public data. It's just a matter of pulling it together, and there's a RAND study that Jesse mentioned that was produced last year that talked about this specifically in Michigan across the country. Member care for our employees, or your employees is next. Do you want to touch on this, or is there anything that we missed maybe in the previous discussion?
Well, so at the beginning we talked about there were two areas of focus that really differentiate us in the market, and that's savings and experience. And to this point, I think we've talked a lot about some of the ways that we drive savings. And so I think it's shifting gears, if you will, shift attention to the experience, but more specifically the member experience. I think I was alluding to this a little bit earlier, but again, in all sincerity, it's really challenging, I think, for us to find the right words that accurately describes the true value of what our member care team actually delivers on a day in and day out basis. The level of member advocacy goes far beyond anything I've ever seen. The bullet points here are not an exhaustive list, and as we go through the various slides, I'll provide a little bit more granularity in terms of what this actually means through the lens of a member.
And I just got a question come through. Are you ready to field a question, Jesse?
Sure.
Okay, let me see if I can paraphrase. It's a little bit long. All right, so you don't work with contracts necessarily. You might establish direct contracts here and there. So the general question is, how does the patient even have a provider agree to see them? without a network? What's that process look like from a member standpoint?
Yeah, I would get that in just a moment, but I'll take that question here and say that again, there are advantages with not having a network agreement in place. If it is a net new provider, the member is educated beforehand. When the member provides their card, let's say, to a provider, the provider might say, well, we don't have an agreement with Apostrophe, and so they can call Apostrophe as an example on the back, and we can negotiate a fee for those services right there at that time. Remember, we talked earlier on about the cash pay option, and again, that would save both the member and the plan that cost, but we'll leverage that interaction in a very meaningful way between the provider and the member to establish care on an ongoing basis and contract with them going forward. And so our provider relationships team will follow up with that provider almost immediately, or even while the member's in office, to negotiate and discuss how we can alleviate this on a go-forward basis, particularly if the member wants to continue to receive care there.
And I'll just add that Apostrophe provides an ID card, just like every other ASO, TPA provider, or carrier or partner in the marketplace. And once that relationship established between Apostrophe and the provider, these things get sorted out through some of the methods that Jesse mentioned. It's a lot less wild west. It's more making sure those providers just pick up the phone and call Apostrophe. The better analogy might be there are more than just 4 or 5 carriers in the marketplace. There's probably 50 to 100 TPAs across the country, if not more, that will have a name that most providers won't recognize at first. But once they pick up the phone and do eligibility check and understand the plan, that's when a lot of that stuff gets sorted out. So great question, whoever asked that.
Yeah, and again, I would say that it's been our experience that given the way that we contract and pay the providers, it's interesting. I mentioned at the onset that providers are actually, we view them as a stakeholder. And so when they learn how we do business, we'll pay them within 21 days, we'll pay the member share. They are excited to work with us because it's materially different than the status quo. And if you think that the employees and the employer don't like the status quo, you ought to talk to the providers themselves and feel how they get their reaction to some of these network agreements as well. It's really a source of great frustration for them as well.
We have about 7 minutes left if we want to try to stay honest to a 1 hour mark. I know we got a late start, so I'll leave it to you to let me know how best to use our last few minutes here together, Jesse.
Why we can just, I think there's a few more slides. We can go through this member experience. I'm sure we'll, if there's HR people on the phone, benefits-oriented HR people on the phone in particular, the next few slides I think will really speak to them. So we can go through those relatively quickly.
Perfect. We're still on the member care slide if you want to touch on member pay.
Yeah, if you want to click. You want to click to the next one?
Sure. Okay. Provider outreach.
Yeah. So provider outreach. This is similar to what we were just talking about. All providers treat it as in network. We don't contemplate in or out of network, so members are free to go wherever they like. Of course, there are advantages that come with that, and maybe some challenges at times with greater freedom. And we go to extraordinary lengths to help make the members make smart choices. We'll help them to set appointments. We'll help them keep appointments, call ahead of high care needs, work with them on prepayment options. There's an enormous amount of effort that goes in on the member care team to make sure that member themselves has as we illustrated at the onset, a white glove experience. You click to the next one. There's like about 4 or 5, so we'll just hit these at a high level. Maybe they'll garner some additional questions.
All right, out-of-pocket expenses, education.
Member education. We help members get the most out of intelligent health benefits. I think I said this at the onset. Member care spends quite a bit of time educating members well beyond open enrollment. This is generally where you would probably have to agree with me, Matt, with the traditional ASO, carrier administrated plans. They view profitability by how quickly they can get a member off the call, and so there's very little guidance and assistance anytime a member has problems. Our member care team is not measured by how quickly they can get a member off of the phone, but rather the overarching member experience, and then we quantify savings and experience and report that back to the plan. So we actually have a Slack channel that's dedicated to the member compliments of our member care team as they receive them on an ongoing basis. And those within the company, even though it's redacted of PHI, we can see these communications that come back. And quite frankly, it's one of the things that it's a constant reminder of why we are all doing what we do, as members report back to us that this experience is wholly different than how they've engaged in healthcare in the past. And so if you want to move on to the next one.
Okay, member pay, simplified billing.
Yeah, I think we kind of covered this one, so I'm sorry that it's a little bit redundant. One audited statement, one balance to pay. Again, taking the complexity out of healthcare from a member's perspective.
Okay, balance bill support. So we haven't touched on this too much. As Apostrophe does have part of their model bill to pay providers as a percentage of Medicare. In the event a provider decides that they don't accept that amount and push a balance bill to the member, how does Apostrophe support this process?
Yeah, great question. I'm glad you asked it. It might be surprising to a lot of people to know first and foremost that this has often been built up, particularly by, let's say, the opposite side, the establishment, right? That if you go with a network agreement that your members are going to get balance billed left and right. And that's how they keep people constrained within the game that they want to keep them contained within. And so what you should know is that balance bills, they do happen. They happen in the BUCA administered plan as well. And there's a myriad of reasons how a balance bill, the genesis of a balance bill or a surprise bill can happen. But what I think would surprise a lot of people is that across our entire book of business, we see less than 3% of all of our adjudicated claims are actually balance bills. And nobody, and I mean nobody, works more or advocates more for a member to get the balance bill from the provider written off. Remember, I said also that we leverage that interaction with the member and the provider to insert ourselves and negotiate a longer term agreement for the benefit of the plan and for the benefit of the member as they seek additional care, perhaps from that provider. So one of the other things that we do is we ask the employer to set an approval limit as a percentage of Medicare within the SPD in terms of what we have flexibility in negotiating a balance bill up to a percentage of Medicare. And so again, giving the plan greater control over how they are purchasing healthcare, but the cost of advocating and doing all of this stuff is built into our PEPM. And I think it would also be surprising to know that of those balance bills, roughly 75% are settled within 35 days. It's been made into a boogeyman that we're not seeing it on our end. That said, we are seeing an increase in balance bills. We attribute it to the pandemic. It's happening in different markets with different healthcare systems, and quite frankly, they're doing it as a means to try to offset losses that they're seeing from the lack of utilization within their own facilities. And I don't want to get too far down this path, Matt, because we can have a long discussion on what this looks like coming out of this pandemic. But again, balance bills and what we do for members is wholly unique than anybody else in the industry.
We'll save that for Apostrophe PI webinar number 2. I'm going to transition to $0 care with Smart Chopper, but before I do, I'll just mention one thing. Jesse talked about employers controlling the language in their SPD to allot what Apostrophe can pay providers on their behalf. I mean, take a moment after this webinar and think about that and ask yourself, under any other circumstance, do you have control of your spend as it relates to specific services? And the answer is probably no. You are at the mercy of whatever's been contracted within a provider network. and those contracts are different across every single hospital system in the country, and you typically don't know what that starting number is. So that's a powerful message there. I know we were specifically talking about it with balance bills, but I wanted to mention that. So since we're at the 1 hour mark and I'm on Smart Shopper benefits, maybe Jesse, we can just close out in these last couple slides and wrap it up.
Yeah, sure. I'll hit these really quickly. So one of our key differentiators is some of these direct contracts that we've already negotiated around commonly purchased and high dollar services. And you mentioned this at the onset in terms of plan design, steering members to where these agreements might already exist. And so we call them smart shopper options, and they include things like advanced imaging, outpatient procedures in general, lab work, colonoscopy, and durable medical equipment supplies. If you go to the next slide, you'll see what that means on a unit cost basis. Are you there yet?
We are.
Kind of want to vacillate between these two slides. So these are some examples of what that means to the plan and the member on a unit cost basis. And in fact, I'm capturing it over here on the right, which is that if we can educate and navigate and steer members at the point of engagement through a myriad of different methods that we've proven to be successful, then we can direct the member to the highest quality care at the lowest contracted price or a low contracted price. And these are just some examples, whereas a knee replacement might cost $57,000, our cost $20,500. If we can direct a member to this facility, then the plan saves a significant amount of money, and we ask the plan to share in that savings by waiving any co-pays and deductibles to the members, assuming that it will comply with the plan design, and the member pays zero out of pocket. Those are what we call smart shopper opportunities. And then the last slide, I know, because, go ahead.
I just say common sense plan design building, right? Everybody wins here. The member might save a few $1,000s out of their cost share, depending on the plan design. And obviously the group themselves are paying a fraction of what some of the average costs might be on these services. So
yeah, we're driving care to the right venue.
Yep. We're on the last for you.
Just keeping, since we're over, keeping with our values, we charge a flat PEPM for our services. Everything that you've seen included in this is covered in there, including the advocacy, member care guidance, negotiating balance bills, all of those kinds of things. We do not mark anything up or receive referral bonuses. All discounts and refunds that we receive are passed on to our customers.
Well said. I'll close out with just a little comment. So we have a mutual client with Apostrophe. I've been on board for about 16, 17 months now. And, I think a good portion of what Jesse's talking about today has certainly come to fruition. There may be some more information presented by us in the future, but at a high level, we've seen about a 24% cost reduction. That cost reduction has held flat or been projected to be flat here for 2020. It might even be down with the pandemic, but I don't think that Apostrophe can necessarily take full credit for everybody staying home for 3 months. I'm not going to give you that one, Jesse, but
yeah, I'm not asking for it.
And then the member experience, there have been a couple of balance bills that we've talked and worked through, but the majority has gone quiet, just like a traditional health plan would. So I think, long story short, we do have a model here in place that has worked for a customer here in Michigan, and hats off to Jesse and your team for that.
Thanks, Matt. Appreciate the opportunity to be with you and your customers and prospects today.
Anything else you want to share before we close it out?
I think I'm good.
Folks, thanks for joining us. This is recorded, so if any of your team members want a listing for the recording, happy to send it out. Feel free to reach out to me or Laura, who likely sent you the invite. Once again, thank you for your time this afternoon. And Jesse, thank you for your time representing Apostrophe. Great job.
Thank you so much, Matt. Have a wonderful day, everybody.
Take care, all.